In another video, we mentioned that contrary to high anion gap metabolic acidosis, when there's a loss of bicarbonate, the body compensates by increasing chloride levels to maintain electrical neutrality, a condition known as hyperchloremic acidosis, or normal anion gap metabolic acidosis, or non-anion gap metabolic acidosis. This is a type of metabolic acidosis characterized by normal anion gap, typically between 8 to 12 milliequivalents per liter. Once a diagnosis of normal anion gap metabolic acidosis is established, the next step is to determine the underlying cause. So, what is the urinary anion gap? Before we delve into this, here's a small introduction. Ammonium is the most important form of acid excretion by the kidneys. Ammonium excretion is the primary mechanism by which the kidneys excrete acid, playing a crucial role in maintaining acid-base balance. Under normal conditions and in response to acid-base disturbances, renal ammonium excretion is quantitatively the predominant component of renal net acid excretion. However, direct measurement of urinary ammonium is not commonly performed in clinical laboratories, making it challenging to assess accurately. Instead, surrogate markers like the urinary anion gap and urinary osmolar gap are often used. Studies have shown that the UAG urinary anion gap is not a reliable predictor of urinary ammonium, and direct measurement of urinary ammonium is recommended for better clinical assessment. Back again, the urinary anion gap is a calculated value that reflects the difference between measured cations, sodium and potassium, and measured anions, chloride, in the urine, with the assumption that the unmeasured cations are primarily ammonium, which is excreted as ammonium chloride, and the unmeasured anions are bicarbonate and other organic anions. The negative urinary anion gap indicates an increase in renal ammonium excretion, which corresponds to an increase in chloride excretion, suggesting an extrarenal cause, such as gastrointestinal bicarbonate loss, for example diarrhea, or proximal renal tubular acidosis, RTA, where renal distal acidification is intact. Conversely, positive urinary anion gap indicates impaired renal ammonium excretion, which corresponds to a decrease in chloride excretion, suggesting a renal cause such as distal RTA, hypoaldosteronism, or early renal failure. After calculating the urinary anion gap, measure urine pH. In normal physiology, the kidneys respond to metabolic acidosis by increasing the excretion ammonium, which causes the urine pH to decrease. Back again, in distal RTA, there is impaired renal ammonium excretion leading to an inappropriately high urine pH. So a urine pH greater than 5.5 in the presence of metabolic acidosis suggests distal renal tubular acidosis, whereas a urine pH less than 5.5 suggests proximal renal tubular acidosis, or gastrointestinal bicarbonate loss. Evaluate serum potassium. Hypokalemia is often associated with proximal RTA and gastrointestinal bicarbonate loss. Hyperkalemia may indicate hypoaldosteronism or type 4 RTA. Consider urinary osmolar gap. If the UAG is inconclusive, calculate the urinary osmolar gap to estimate urinary ammonium excretion more accurately. A urinary osmolar gap less than 40 millimoles per liter indicates impaired ammonium excretion.